right, good morning, everyone. Let's get started. It is my pleasure to welcome you all to today's Region 4 Project Echo session from the Emory University Serious Communicable Diseases Program, run in conjunction with the Southern Regional Disaster Response System and the National Emerging Special Pathogens Training and Education Center. My name is Gavin Harris. I'm an adult infectious diseases and critical care physician, the Director of Education and Outreach for Emory's Serious Communicable Diseases Program, and your host for today. As always, before we begin, please know that we will be recording this session and your data, while used for informative purposes, will be kept confidential. Now, for those unfamiliar, ECHO is an acronym standing for Extension for Community Healthcare Outcomes, founded by the University of New Mexico. It's designed to disseminate and amplify best practices in a collaborative and interactive manner. And if you are interested in participating in future sessions, please reach out to us. Details will be at the end and on our website. As always, if there are any issues during the webinar, please send us an email or type in the chat. And if you'd like to ask a question during the session, please type it into the Q&A feature. We'll do our best to answer questions in real time, and we'll discuss as many questions live as we are able. But if we do not get to all questions, we will post a recap addressing those topics on our website when the recording to this session is available as a podcast next week. Now, importantly, the presenters and the planners of this session have no financial conflicts of interest with ineligible companies to disclose. And here's today's agenda. We're going to start with the Region 4 SITREP, as always, and this will be followed by our case and didactic presentations with a moderated Q&A to follow. And now it's my honor to introduce our guests for today. First, I'd like to welcome Dr. Yogi Ermayas, a second-year infectious diseases fellow here at Emory. Dr. Ermayas holds a master's degree in public health, has previously worked at the Centers for Disease Control in the Infectious Diseases Pathology branch and in the Division of Reproductive Health. Staying true to her clinical interests in global infectious diseases and public health, following fellowship, she will be joining the Epidemic Intelligence Service as a CDC EIS officer in 2026. Next, I'd like to welcome back my colleague, Dr. Lindsey Gottlieb, Associate Professor in the Division of Infectious Diseases here at Emory, and the Hospital Epidemiologist at Emory University Hospital and Emory University's Orthopaedic and Spine Hospital. Dr. Gottlieb not only directly provides care for patients with infectious diseases in the inpatient and outpatient settings, but as hospital epidemiologist, she provides medical and operational direction to infection prevention and control activities. Her research interests and focus lie in understanding the efficacy of transmission-based precautions, outbreak investigations, and reduction in healthcare-associated infections. And lastly, I'd like to welcome Dr. Melissa Tobin DeAngelo, the Georgia Department of Public Health Team Lead for Food and Waterborne Diseases Surveillance and Outbreaks. She has served in this role for more than 20 years, including 15 as the Emerging Infections Program Principal Investigator. Throughout her tenure, Dr. Tobin DeAngelo has led various initiatives to improve enteric disease surveillance quality, streamlining electronic laboratory reporting, and testing statistical methods for improved detection. Welcome to you all. And now, to place this session in context, the Emory University Serious Communicable Diseases Program, in conjunction with the SRDRS, puts together situation reports on special pathogens of concern for our region, HHS Region 4. These SITREPs are typically published on our website, social media channels, Emory Department of Medicine YouTube channel, and listservs. So here's the current HHS Region 4 Special Pathogens SITREP. Africa. First to Nigeria, where Lassa fever continues to circulate. In the most recent official report concluding the week of the 23rd of November, there's been a total of 8,801 suspect, 1,012 confirmed, and 185 deaths, with a small number of increasing cases. For the year, this equates to a case fatality rate of 18.3%, still 2 percentage points higher than the previous year. The country has now entered the dry season, and we do expect case counts to rise. The risk of global spread is currently low to moderate. Next, to the Democratic Republic of Congo for some positive news. On the 1st of December, the Ministry of Health declared the end of the country's 16th outbreak of Ebola virus disease. A total of 64 cases, 53 confirmed, 11 probable, and 45 deaths were recorded, which is a case fatality rate of 70.3%. The country is now in a 90-day period of heightened surveillance. And to Ethiopia, where the country has been in the midst of its first recorded Marburg virus outbreak since the 14th of November. The outbreak is occurring in the South Ethiopian regional state in the Omo region, bordering South Sudan, an area known to have much cross-border movement and political instability. The most recent report from the Ethiopian Ministry of Health notes 13 confirmed cases with 8 deaths, including infections among several healthcare workers. International teams have been on the ground to assist, and investigational countermeasures, including vaccines, have been deployed. The risk of global spread is currently low. And to mainland Western Europe, where France has confirmed 2 imported cases of Middle East Respiratory Syndrome, or MERS, in travelers from Oman. These are France's first cases since 2013, and both patients, though hospitalized, remain in stable condition. The patients recently had returned from a group tour of 35 people where, in Oman, they ate dromedary camel meat. The first patient was confirmed in Lyon and the second in Vienna, an asymptomatic contact of the first. MERS has been known to cause human-to-human transmission, and health authorities are currently monitoring for subsequent cases. Global risk of spread remains low. And lastly, the Washington state resident who was discovered to have influenza A H5N5 last month, a highly pathogenic avian influenza subtype, has died. Little is known about the patient aside from the fact that they were described as an older adult with underlying health conditions and had exposure to mixed domestic and wild birds near home. No secondary infections have been detected, and the risk of spread remains low. Finally, there have been no reports of suspect or confirmed patients with special pathogens of concern in Region 4 at this time. For more resources, visit us on the web at scdp.emory.edu. And now, as always, before we delve into the main topic at hand, I wanted to first pose some interactive poll questions to our audience to gauge our base comfort level with this topic. They should be up on the screen now. The first question, how knowledgeable do you feel about current monitoring of foodborne illness risks? And the second, how confident do you feel about the appropriate clinical management of a patient with foodborne illnesses? If the audience could please vote now. All right, if we could show the results of that poll, please, up on the screen. And thank you for that. We have quite a wide range from not at all knowledgeable to extremely knowledgeable for the first question about the risks of foodborne illnesses, and also a very fair spread for the second question as well. So our panelists certainly have their work cut out for them, but we also hope that the audience finds this quite educational and useful. So with that, let's begin. I'm going to turn it over to Dr. Yogi Ermias.
Thanks for having me, everyone. I'm going to go ahead and share my screen here. All right. As Dr. Harris mentioned, my name is Yogi Ermias. I'm one of the second-year infectious disease fellows in the adult section here at Emory, and I'll be presenting this foodborne illness case for you all. So let's go ahead and start with the case. We have a 32-year-old man. He has no significant past medical history. He presents to the emergency room with fever, abdominal pain, and loose stools. A little bit about the history of his present illness. He was in his usual state of health until about 7 days before admission, when he started experiencing sudden fatigue while at work. The next day, he developed low-grade fever to 100.5, and then over the next 4 days, his fatigue and fevers worsened, requiring him to call out of work. During this time, he also developed diffuse abdominal pain and 5 loose, non-bloody bowel movements daily. The symptoms were not improving, so he decided to present to his emergency room for further evaluation. A little about his recent travel history. About 1 week before symptom onset, he traveled to India for 3 weeks, where he was visiting friends and relatives. He admits to eating undercooked meats and drinking local water. He interacted regularly with a large number of different animals on his family's farm, and he frequently drank milk directly from the cows. He did not have a pre-travel evaluation prior to this trip. Some other relevant social history. He lives alone in Marietta, Georgia, in a house. He has a 6-month-old puppy. He works as a software engineer, and he's not currently sexually active. He gets evaluated, and these are what we find on physical exam. So he is febrile, he has tachycardia, and he has borderline low blood pressure at this point. When you see him, he's fatigued appearing, but no acute distress. His heart is tachycardic but regular. His lung exam is unremarkable. His abdominal exam is notable for a mildly distended abdomen that's diffusely tender to mild palpation. And on his skin, you note a faint erythematous macular rash across his trunk. Some of the labs start coming back, and as you can see here, his liver enzymes are slightly elevated at 67 and 88. He's slightly leukopenic and anemic. So let's pause for a case summary. This is a 32-year-old man with no significant past medical history. He presents with over a week of fever, abdominal pain, and loose stools after a recent trip to India. He's found to be febrile and tachycardic with transaminitis, leukopenia, and anemia. This clinical picture is concerning for sepsis, secondary to an acute infectious diarrhea. So let's talk a bit about what our differential for infectious diarrhea is in a returning traveler. This is based off of the CDC Yellow Book website. And so these are the most common pathogens that we identify for infectious diarrhea in these returning travelers. As you can see here, there are many organisms that we think about causing diarrhea within our own country, and some that we typically see in other countries, such as Salmonella typhi and cholera. And then if you have a patient who has been having diarrhea for a prolonged period of time, usually we think greater than 14 days, you can start thinking about some of these parasitic infections. And so when should we really consider targeted testing when we have someone with acute infectious diarrhea? A lot of this guidance comes from the 2017 IDSA clinical practice guidelines for the management of infectious diarrhea. And so we'll go through some of these recommendations over the next several slides. Stool testing tends to be the cornerstone of testing if that is indicated. And so you should consider it if you are concerned about certain bacterial infections listed here in patients who have very severe symptoms, such as abdominal pain or bloody or mucoid diarrhea, and very specific epidemiologic risk factors. You can consider adding blood cultures if there are systemic signs of infection, if the patient is very young, less than 3 months old, or those who are immunocompromised, or if there's concern for typhoid fever. And so let's delve a little bit more into what kind of testing exists in this scenario. So for stool-based testing, historically we've used cultures, though this is becoming less common. And more commonly, we're using culture-independent diagnostic tests such as PCRs and antigen tests on the stool. Obviously, blood cultures can also be collected. And I just want to highlight here that the recommendation is not to collect a lactoferrin and fecal leukocytes, as these don't really help in differentiating the type of pathogen. So for this patient, the workup that was included were blood cultures, stool cultures, a GI bacterial PCR pathogen panel, a C. diff assay, a stool ONP, though this may not have been as high yield in a patient who had diarrhea for less than 14 days, and then a lactoferrin, which again is not necessarily in line with the guidelines. And so now we're concerned about infectious diarrhea. When should we think about including empiric treatment for these patients? And so this is broken down based off of the type of infection that you're concerned about. So in patients who have watery diarrhea in general, we try to avoid using antibiotics, as these are usually not caused by a bacteria and more often are viral. Some of the exceptions are in immunocompromised patients or young ill-appearing infants, as noted by the guidelines. If someone is having bloody diarrhea, it's a little less stringent. So if there's an infant less than 3 months old where you're concerned about a bacterial infection, if you're at all worried about Shigella in the patient, or if you have an international traveler who comes back with a fever, those are times to think about empiric treatment. And typically we use fluoroquinolones or azithromycin in adults, or a third-generation cephalosporin or azithromycin in children. Though note in returning travelers, it's important to think about the resistance patterns of the organisms that might be circulating in that country. And then if you have high suspicion for typhoid fever or sepsis or bacteremia, you want to try to use a broad spectrum antibiotic, usually a third generation cephalosporin or higher. So let's go back to our patient. He presents with the symptoms that we talked about. He's empirically started on ceftriaxone. And the next day, unfortunately, he becomes hypotensive and continues to fever. He requires vasopressors and so goes to the ICU. His testing is pending at this point, and he's brought in from ceftriaxone to meropenem. Some of the results start coming back, and as you can see here, most of our testing so far is negative, except for a positive lactoferrin. And eventually we find out that this patient has Salmonella typhi, as detected in the blood culture, and then also on the GI stool pathogen panel. So let's talk a little bit about typhoid fever. It's caused by Salmonella enterica typhi, or as some call Salmonella typhi. It's endemic to many parts of the world outside of the US, mostly in Latin American countries, Asia, and in African countries. Transmission is via fecal-oral route due to contaminated food and water. And the incubation period can be quite long, anywhere from 60 to 30 days, though on average is just over a week. It has a slow onset compared to many other types of infectious diarrhea, several days to weeks, and generally all patients will have fever, fatigue, anorexia, and headache. Often patients will have abdominal pain. In adults, constipation is common, though diarrhea can happen, and diarrhea tends to be more common in children. And then later in the presentation, patients often develop maculopapular rash or hepatosplenomegaly. This slide I included less to go through all the details, but more so to talk and see the complications that can happen from typhoid fever. And as you all can tell, there are many organ systems that can be involved. So it's very important to have a high index of suspicion for this in returning travelers, as it can cause multi-organ failure and death. So let's continue on with our patient's hospital course. The next day, we have the results that we discussed earlier that come back for Salmonella. The day after, his fever finally resolves and he comes off of vasopressors. The sensitivities from the blood cultures come back, and we find that the Salmonella is pan-sensitive. So he ends up getting narrowed back to ceftriaxone. And then 7 days from his initial admission, he's finally discharged, and he's planned to complete a total of 14 days with levofloxacin. I think one thing that's important to highlight specifically about typhoid fever and Salmonella typhi is that it's one of the few causes of traveler's diarrhea that has a vaccine. And so there are two vaccine options that are available. One is a live attenuated oral that lasts 5 years, and then the other is an inactivated injectable vaccine that lasts 2 years. It's also important for patients to know about food and water precautions when they travel abroad to try to help protect themselves. So discussing and having a pre-travel evaluation can be critical so that patients can know that avoiding local water is important, using bottled water, avoiding raw meats and eggs, and only using for eating fruits and veggies that you can peel or wash yourself, and then using appropriate hand hygiene prior to eating. So some of the key takeaways from this case, foodborne illnesses can present with abdominal pain, diarrhea, and fevers, if severe. This includes typhoid fever, which has a more insidious onset. Foodborne illnesses can be detected by both culture and culture-independent stool testing and by blood cultures in select patients and settings. Empiric therapy should be reserved for diarrhea in select populations, such as young infants and travelers with fever, if typhoid fever is suspected, or if septicemia or bacteremia is suspected. And finally, typhoid fever can be prevented by getting vaccinated and practicing food and water precautions while traveling to endemic areas. These are my citations. And that is all.
Thank you so much, Dr. Armias, for that fantastic in-depth presentation. We're going to turn over to Dr. Gottlieb now, and while she's getting set up, just a reminder to the audience that if there are questions, please feel free to put them in the Q&A part of the chat. All right, Dr. Gottlieb.
Thanks. Good morning, everyone. So I'm going to be talking about foodborne illness specifically in the healthcare setting, and I have nothing to disclose. So first, I want to acknowledge that there's a lot of different terms out there that are used by people both in the community and even in the healthcare community that I don't necessarily think are very well defined. And I'll say as an infectious disease physician, I'm often not sure what somebody is talking about when they say that someone might have food poisoning, or in particular, the dreaded term, the stomach flu, which I always find to be a bit confusing. But all of these different buckets have one thing in common, that they all are potentially under this overarching category that we're focusing on today of foodborne illness. Dr. Armias already mentioned this guideline from the Infectious Disease Society, co-authored or first authored by one of our colleagues here at Emory, Dr. Andy Shane. And I think this is really a great tool and starting point as we think about a patient who's presenting to one of our hospitals with signs or symptoms that may be concerning for a foodborne illness or infectious diarrhea. And there's a lot of different ways to categorize the disease processes with which patients present that can help us understand what the most likely causative pathogen might be. First, we think about the overarching way in which the organism causes disease. There's some bacteria like Staph aureus and Bacillus cereus that have a preformed toxin that really is what is driving the clinical manifestations of the disease, and often is going to be really fast onset because that toxin's already there, and often will present with more of a vomiting predominant syndrome. Whereas there's other pathogens like Salmonella that we just heard about, which may cause more of a pathogen direct mediated infection and often present with lower GI symptoms. Not all vomiting predominant illness is caused by preformed toxins. I mentioned Bacillus cereus and Staph aureus, but certain vomiting predominant illnesses can be caused by viruses as well, like norovirus. And then we've got bacteria or oftentimes parasites that can cause more of a diarrhea predominant illness, things like Shigella or Cryptosporidium. And then we can think about for patients who are coming in with diarrhea, is this a non-inflammatory watery diarrhea? Again, making us think more about things like parasites, Cryptosporidium or norovirus, or an inflammatory diarrhea, which can cause more systemic illness, bleeding, abdominal pain with things like Campylobacter, but also some of the other organisms we just mentioned, Shigella and Salmonella. So a lot of different overlapping ways to think about those clinical clues. But there's clinical clues that are beyond those broad categories that may help us hone in even more on what might be causing the clinical presentation. Things like the duration of symptoms prior to presenting to care, or duration of symptoms after a potential exposure, as well as how quickly those symptoms resolve. And all of these tables within that guideline can help us get a sense of what organisms are most likely. And understanding what organisms are most likely are really important because, as Dr. Ermias mentioned, not all diseases really should be treated with antibiotics, and there are some that actually might worsen with antibiotics. Of course, in the world of ID, we don't just care about the signs and symptoms. We really care about what risk factors, what epidemiologic links do our patients have to a certain illness. And so, again, in the same guideline, there's a great table that categorizes exposures, some of which are not foodborne, so won't as much be the focus of today. But the top box that I've highlighted are those foodborne risk factors. So there's going to be certain organisms you think about more with dairy products, and in particular unpasteurized dairy products, things like Listeria or Brucella, depending on the region where the patient traveled. Whereas other food exposures like undercooked meat or poultry might point you more towards other organisms like Salmonella. And then not just the food itself, but where was that food consumed? So cruise ships are something that always makes our heart race a little bit, just given the shared food sources often in large buffets in those settings, and things like norovirus are classically associated with those exposures. But we can also think about our local epidemiology, and I think we'll hear a little bit more about this from our next speaker. But one great resource that's publicly available is FoodNet, which is part of CDC's Emerging Infections program, and a way to track certain high consequence causes of foodborne illness in your community to understand if a person is presenting with symptoms only having been in this local community, what are the most likely causative pathogens to be acquired in your community. But when I think about how to approach these diseases from the healthcare setting, I really want to think about what's going to actually make people present to care, because a lot of the causes of foodborne illness are mild enough that a patient might not even come to the healthcare system. But there's certain disease presentations that make them more likely to come to my emergency department. So number one, is it a disease that causes enough watery diarrhea or vomiting that you might be dehydrated or unable to tolerate food or liquids? And that's going to make me think often about things like norovirus in particular. Bloody diarrhea and systemic illness, of course, is just scary to see as a patient, but if a patient has associated fever or pain, that may be a reason to present to care. And we've got organisms like Salmonella, Campylobacter, Shigella, all of which might benefit from antibiotics if recognized. But then you also have the overlapping terminology here of either enterohemorrhagic or Shiga toxin producing E. coli, of which O157H7 is most well recognized, which can also cause an associated hemolytic uremic syndrome, and in which case antibiotics should be avoided. So really understanding what different bugs can cause different presentations and what testing is available, like Dr. Ermias mentioned, can help give you an idea of how treatment should proceed. Then there's the less commonly encountered group of pathogens that can cause presentation for a neurologic illness. So this includes often more toxin-mediated disease from things like botulism, ciguatera toxin, and scombroid. And then last are the pathogens that cause more of a prominent systemic illness with sometimes completely absent GI illness. So Listeria may have a more mild GI illness, and then weeks later, the patient may present to care with more of a serious meningoencephalitis. Vibrio vulnificus, so classically associated with exposure to raw oysters, although it can be associated with other seafood as well, which can cause an overwhelming sepsis or even a necrotizing fasciitis. And then typhoidal salmonella, like we just heard about. But what I was really asked to focus on is how we really think about those pathogens that have an outbreak potential in the healthcare setting. And when I think about foodborne illness and outbreak potential, there's really one organism that comes to mind, and that's norovirus. And I think for many of us in infection prevention and healthcare epidemiology, we hear norovirus and our brains go to this. This is really the dreaded pathogen when we think about foodborne illness in the healthcare setting. And I'm going to get into a little bit of why. So what is norovirus? It's a single-stranded RNA virus in the Classiverity family, which also includes sapovirus. It's very stable in the environment, so it can be found to be viable on surfaces for 7 days and often even much longer, and is unfortunately resistant to many conventional cleaning products, even those used in the healthcare setting. Like many of the organisms you're hearing about today, it's most commonly transmitted through the fecal-oral route, but notably requires a very low viral load or inoculum in order to be transmitted between individuals. Getting more into the nitty-gritty, that transmission can occur through direct contact, but more often through indirect contact with either contaminated food or water, or even surfaces that those viral particles have contaminated, but also can be spread through aerosolized particles, most often in the setting of an individual who's been vomiting. What's scary is that the virus can actually be shed in an individual's stool for about 4 weeks, and this can actually be much longer in individuals who are immunocompromised and can be shed in the day or two preceding onset of symptoms. Norovirus can be detected year-round, but cases really peak in the winter, so we're really hearing a lot about this right now going into the December month. And incubation period is relatively short, like many of our foodborne illnesses, about 12 to 48 hours typically from exposure to clinical symptoms. There is a broad spectrum of potential clinical presentation, and including some individuals who, for whatever reason, remain asymptomatic even after being exposed to norovirus. But classically, norovirus causes a really acute onset vomiting syndrome with a lot of abdominal cramping, often but not always a component of watery diarrhea, and then about half of individuals can have an associated fever as well. And after infection, there is not complete immunity. So this is still not perfectly well understood. There may be some stronger immunity between the same genotypes, but when you start talking about other genotypes of norovirus, there's really not immunity. And so many of the characteristics that I just described of norovirus are the same things that facilitate outbreaks in the healthcare setting. And I've highlighted those items, including viability on surfaces, difficult to clean, the low inoculum required for transmission, the potential for it to be aerosolized, how long it can shed in an individual's stool, and the fact that we don't have complete prior immunity after prior infection. So this is from a survey that's a little bit old at this point, but of infection preventionists throughout the country talking about what type of outbreaks they've most commonly had to investigate. I think if you were to do this survey again now, you'd see Candida auris jumping much higher on the screen. We didn't even know about Candida auris in 2012. But of these organisms that they asked about, norovirus was the most common proportion of outbreaks, 18%. And outbreaks affected facilities not just in the acute care setting, but also behavioral health, psychiatric facilities, and long-term care facilities. I'm going to describe one such outbreak that was published in the literature that I think is just really emblematic of why I showed you that scary movie image. So this took place at an academic tertiary care center, much like ours in Maryland a while ago, and started with 2 patients in their CCU who were both actually healthcare workers. And those were their index cases. They were recognized to have an acute onset GI illness, had been diagnosed with norovirus, and there was known to be norovirus in the community at that time as well. They were quick to respond to this outbreak. They defined a case that did not actually require testing, given how many patients and healthcare workers ended up being involved in this, but had strict clinical criteria and started active surveillance among staff and patients for those symptoms. Throughout the duration of the outbreak, they identified 265 healthcare workers and 90 patients who met the case definition, the majority of whom were clustered in a couple of units. Shared findings in their investigations included eating of communal food, use of communal bathrooms, where unfortunately some individuals ended up being sick, and then vomiting by staff in areas that facilitated early spread. Infection prevention measures were initiated in a stepwise fashion. Of course, they started emphasizing and re-educating the basic infection principles, the importance of hand hygiene, cleaning our environment, and reusable equipment. They started visitor screening, they restricted individuals who were symptomatic, and it got to the point where they actually prohibited all visitors who were not a necessary care partner when the initial screening was not effective enough. They suspended all group meals, they instituted enhanced cleaning with increased frequency, adding new surfaces to their cleaning protocols and requiring bleach to be used as a cleaning product. They cohorted care teams so that certain providers were only caring for symptomatic or asymptomatic individuals. And they even implemented universal contact precautions where they required everyone to wear a gown and gloves on a unit where there had been any outbreak. This got to the point where they actually had to briefly close one of the units for extensive cleaning for about 24 hours. They threw out a lot of stuff, including furniture that couldn't be cleaned, and performed even more intensive cleaning of those surfaces. And you can see on the right that they were eventually able to see a downtrend in the number of new cases and a resolution of the outbreak, but not after clearly a huge impact, both financially and clinically, on their ability to care for patients. So the takeaways of how to prepare for and respond to an outbreak like this are really the same as what we emphasize whenever we're talking about pathogens with transmission potential in the healthcare setting, and that's identify, isolate, and inform. So first, we must identify patients quickly who are presenting with an acute onset GI illness, and recognize that we do have a lot of ways now in most of our acute care facilities to quickly test for causes of GI illness, often through the multiplex PCR panels that Dr. Ermias mentioned. Once we've identified them, we want to make sure that patients are isolated in a private room if available, but at a minimum with utilization of gowns and gloves for all patient care, so under the umbrella of contact precautions. Hand hygiene should be performed with soap and water whenever available, but we of course want to emphasize that what's most important is just performing hand hygiene at every step of care, and really prioritize dedicated bathrooms given the potential for aerosolized transmission if a patient really is vomiting. We also don't want to forget that sometimes a surgical mask is required as part of standard precautions if somebody caring for a patient may be involved in cleaning or involved in a patient who is heavily vomiting and there's risk of droplet or aerosolized transmission. And then making sure that you're utilizing effective cleaning products whenever cleaning the room of a patient who has a GI illness that may be norovirus or something similar. And there is a specific EPA list G for norovirus approved products, but really this overlaps nicely with our CDIP approved products. And then lastly, want to make sure that infection prevention at your facility and at a transferring facility, if a patient came from a group area, is aware of the diagnosis so that they can quickly respond and make sure that the area in which they came from has been appropriately cleaned and evaluated. And then the last point I'll make is don't forget about healthcare workers. We often think the most about our patients, but as you heard in the case example I shared, there were actually a lot more cases in healthcare workers than in patients. And it's really important to have close collaboration with your occupational health colleagues to understand what your work restrictions are and make sure that people aren't cleared to return to work until they're symptom-free. And I'll end there.
Thank you so much, Dr. Gottlieb. And now for a public health perspective from Dr. Melissa Tobin-D'Angelo.
Good morning.
And while you're getting those slides up there, I'm just going to remind the audience that our post-session resources, including a podcast, our presentation slides, and again, our responses to our unanswered questions will be found on our website next week, and you will get a notice saying that they have been posted. So, Dr. Tobin-D'Angelo, the floor is yours.
Okay, I'm Melissa Tobin-D'Angelo, one of the medical epidemiologists at the Georgia Department of Public Health, and I'm using several terms in this presentation: foodborne or enteric illness, as one of the previous presenters sort of described. Sometimes there are a lot of different terminologies that are relevant. I'm going to be discussing foodborne disease surveillance in Georgia, the various collaborations that we have, and I'm going to also end by showing just some snapshots of surveillance and outbreak data from various places. So this is a map of the state of Georgia broken down by our public health districts. We conduct surveillance out of our state office, but have a really supportive role. Our district epidemiologists are really the primary ones conducting enteric disease surveillance and investigating outbreaks if they are limited to their jurisdiction. We at the state coordinate, lead investigations, especially multi-jurisdictional ones, and support our districts. The core of our infectious disease surveillance is notifiable disease reporting, and the link to our website is listed at the bottom left, and that is just a screenshot of part of our notifiable disease poster. And many of the bacterial and parasitic infections mentioned earlier are listed to the right. So I consider that notifiable disease surveillance is really our core minimum surveillance, and there are a lot of other complementary systems, mostly based out of CDC. And we in Georgia are fortunate enough to participate in some of the systems that are represented by all states, NARMS and PulseNet, but also FoodNet, which was mentioned by Dr. Gottlieb, and a different system called OutbreakNet Enhanced. And I'll get into a little more detail, but all of these have various foci of expanded data collection, enhanced surveillance, enhanced isolate and specimen submission. So FoodNet looks like we have a little overlap in graphics, but FoodNet essentially is Georgia and several additional states or parts of states that participate, and we estimate the number of foodborne diseases, monitor trends over time, and attribute illnesses to specific foods and settings and disseminate the information. We contribute to CDC's FoodNet FAST data dashboard, which I'll show some examples from later. We also collaborate in special projects to define burden and create attribution estimates for different foods or classes of foods. And we've also participated in other studies, cohort studies, case control studies, a variety of surveys. There is typically an annual MMWR summary that is released. That this year we did not have one, but you can find previous years' publications on CDC's website. So this is kind of a complicated figure, but I'm trying to demonstrate some of the overlaps and separations of some of these surveillance systems. And one point I really want to make relates to FoodNet, because there was some information in the news several months ago about CDC FoodNet cutting some of the historically included conditions, those are highlighted in yellow, from their surveillance program. So I understand that there are several different and overlapping surveillance systems. There are some disease specific. I've highlighted in that area Vibrio and Listeria. Standardized surveillance systems that all states participate in. We have our notifiable disease surveillance systems. OutbreakNet Enhanced is a little more focused on rapid interviews and outbreak detection and investigation, and also has some overlap with the FoodNet pathogens. But I think that in Georgia, we are trying to, the best we can, continue with surveillance for these now optional pathogens, as I don't think that these other systems fully replace the benefits of FoodNet surveillance. So moving on to two of the systems that are more laboratory-based. NARMS stands for the National Antimicrobial Resistance Monitoring System. This is a national system. It includes human bacterial isolates that all state health departments submit a selection of. It also includes food samples, animal samples, and there is a separate dashboard on CDC's website called the BEAM dashboard that houses the NARMS data. And this snapshot is just showing distribution of ciprofloxacin resistant Salmonella typhi. And you can look at trends. You can do a bunch of filtering by pathogen and by specific antimicrobials even. PulseNet isn't the other laboratory-based national foodborne surveillance system that also includes some waterborne and One Health-related illnesses. And this, by name, originated with a standardized way of doing pulse field gel electrophoresis nationally and even internationally to define different DNA subtypes of enteric infections. So now, of course, we're using sequence-based methodologies, but it is really standardized in that very same way, such that we are naming and characterizing specific strains the same way across the whole country. So I mentioned the assessment of animal and food bacterial isolates in some of our surveillance systems, and I'm just including one slide that defines and outlines the importance of One Health as a framework when we're thinking about enteric disease surveillance. So these are just direct quote taken from CDC's One Health website and also taken from a Georgia-specific One Health consortium that many academic partners and other organizations are represented on. And it just includes really just thinking about how these diseases spread among humans, animals, the environment, et cetera. Other partnerships, the red highlights include our Georgia Department of Public Health partners. We work closely with our food safety colleagues in our environmental health group, and we also work really closely with our public health laboratory. The white box includes a variety of other partners, of course, healthcare providers, clinical laboratories, federal agencies, academic partners I've already mentioned. We have a enteric disease student interview team, and we have students from more than just the three institutions named on this slide who we work with, train, et cetera. State partners, I'm highlighting our Georgia Department of Agriculture. We work extremely closely with them. Our Georgia Food and Feed Rapid Response Team, or RRT, which is an FDA-funded initiative, is housed there, and they host weekly collaborative food safety calls, give us information on trainings, and do a whole lot of other communications that are really valuable, I think, to foodborne disease surveillance in Georgia. These are just a couple snapshots of our data. They're not really meant to lead to a big interpretation or anything, but it's just showing some of the sheer numbers. Salmonella is the big winner in Georgia, not necessarily the case in every other state. This figure shows some of the other bacterial infections, number of cases by year, and the scale's a bit different for some of our parasitic diseases and some of our less common bacterial infections, and that just shows some of the annual numbers for those. I mentioned I was going to show some examples from that FoodNet FAST dashboard. This is spotlighting some salmonella-specific figures. On the left are population rate, so not case counts. Case counts of salmonella compared to the other FoodNet sites actually are the highest in Georgia. But when you look at the population rates, we closely follow New Mexico. And then on the right is the distribution of salmonella serotypes. The green pie is enteritidis. And I want to mention that light green piece and the red piece, which represent, for a variety of reasons, salmonella cases that the isolates were not able to be serotyped. So we have some gaps in that distribution. Speaking a little bit more about salmonella serotypes, this is a busy slide, but represents our top 10 aggregate over 10 years on the left, and then I break it down into hospitalized, which looks quite similar below that. Deaths above to the right, I'm noting that the distribution is a little different. And I'm also highlighting that group of numbers and letters in the red box. That's a Salmonella antigenic formula. All of the named serotypes have Salmonella antigenic formulas. Some of them have names, some of them don't have names. That one in particular is closely related to Salmonella typhimurium. And then the figure at the bottom has a quite different distribution of serotypes. I've limited that just to those that have been outbreak involved. And you see a pretty high number of cases associated with Salmonella Thompson. Those outbreaks have been state-specific outbreaks associated with restaurants or delis. The other two highlighted serotypes have been associated with multi-state outbreaks. I think the Bochum one was produce associated, and the Mandaka one was backyard poultry. So again, bringing in some of that One Health and some of the zoonotic component of Salmonella in particular. A little bit more on outbreaks. We have some very basic definitions of outbreaks and foodborne outbreaks, seeing more of disease X, Y, or Z than you would expect. And then foodborne outbreaks, two or more people who consume the same food and have had similar illnesses. So we identify outbreaks through a variety of means, through our own surveillance data, laboratory sequence data, reports from clinicians, from facilities, long-term care facilities, having norovirus outbreaks, not too uncommon, especially this time of year, affected persons calling about their infection with concern. A different section of that same CDC dashboard includes a national summary of outbreaks. All states are required to submit certain data elements related to our outbreaks to CDC. And again, similar to some of the other dashboards I've mentioned, you can do a lot of filtering and look at trends, look at modes of transmission, look at the different pathogens. To the right, we have a breakdown of selected infections from our own outbreak database, and the colors represent different modes of transmission. So as you can see, the most outbreaks that we see of this class of infectious diseases are through norovirus. There are some foodborne, but predominantly person to person, and Salmonella is our highest number of foodborne outbreaks in Georgia. Not all of these outbreaks are foodborne, though. This is an example that brings in that zoonotic component, the One Health component, and also the importance of that PulseNet system in characterizing that bacterial isolates. These are 3 separate outbreaks of Salmonella typhimurium associated with hedgehog exposure. Georgia had no cases, or at least none that we're aware of, but if you can see the keys and the numbers, I'm not sure how easily readable they are, but most states had 1 case. So routine surveillance isn't really going to find this. It really takes this collaborative work with CDC and other states and the PulseNet system to really identify and respond to these. The next example is also a zoonotic multi-state outbreak. This was actually Campylobacter jejuni associated with pet store puppies. And I'm introducing a new acronym and a new concept here called REP strains. That stands for recurring, emerging, or persistent strains. And CDC has a variety of characteristics that they include when they're defining a REP strain. They typically recur, they cause outbreaks over time. The cases may be increasing over time or persisting over time despite prevention efforts. And most of them have some component of antimicrobial resistance. In this case, that figure at the right shows the breakdown that really shows that these isolates were really very highly drug resistant isolates of Campylobacter. I'm going to end with this slide that is a summary of another rep strain. Here we're going back to Salmonella. And I think this brings in the importance of all of our different surveillance systems, our human surveillance systems, doing our interviews and assessing international travel and food exposures, and then nationally the NARMS testing and the PulseNet testing that includes all these different bacterial isolates from food sources and animals of various parts, which are included in that figure to the right. And this strain continues to cause outbreaks, continues to be associated in particular with chicken exposure and international travel, and has a high proportion of hospitalized patients. So that I think is a nice summary of all the various ways we do public health surveillance and some of the ongoing concerns and work that needs to be done. Here are some selected references and my contact information.
All right, thank you so very much, Dr. Tobin D'Angelo, and thank you to all of our panelists. I'm going to ask them to all come on screen for the last 10 minutes or so for some question and answer. We've had several questions come through, and these were all really fantastic discussions. Dr. Gottlieb, I'm going to start with you. And the question has to do with norovirus. So, we talked or you spoke a lot about the effects that norovirus can have on business continuity and operational logistics in the hospital. But can you speak to perhaps like the clinical matters of norovirus? And, what does it mean in terms of patient outcomes? Why is it something that we really need to be concerned about? Of course, with the immunocompromised population, that's one deal. But what does this mean for patients in our hospital on a daily basis?
Yeah, it's a great question. The good news is that most people who get norovirus recover without complication. It's a really unpleasant disease to have, but the vast majority are not going to have any long-term implications. However, the outbreaks like the one I just described, one interesting finding from them has been that hospitalized patients do more often have severe presentations of norovirus than what's been described in our communities. And I don't think that's entirely surprising. Obviously, the patients in our hospitals are more susceptible to more severe disease, whether because of immunocompromise, as you mentioned, or just being on extremes of age, where even just having severe dehydration can really have a significant impact on kidney function and long-term outcomes. So while for most patients, this is more of a nuisance than anything else, there is a higher proportion of patients who are going to have potential morbidity and mortality associated with this than we would see otherwise.
Appreciate that. Those are some fantastic points. And Dr. Armias, as an infectious disease physician as well, someone who's interested in global health, what are some of your takeaways that you can apply on a daily basis from travel history, from exposure history from these patients? Do you, as the infectious disease physician, do you think about global trends, as Dr. Tobin D'Angelo was mentioning, kind of on a broader basis as well?
Yeah, that's a great question. So I think travel history and specifically social history is something that we as infectious disease doctors think about on a regular basis. It's something that I collect on my patients because it then informs the type of differential that I have for a patient, which can ultimately help me decide on what kind of testing I need to do and what kind of diagnostics and treatment that a patient might need. And so if there are pieces of a travel history or social history that are concerning, I think going back and looking through some of the data that we have available through the CDC or some of our more local health departments can be beneficial so that we make sure that we're doing the right thing for our patients.
Great question. Dr. Gottlieb, I see your hand up.
Thanks. Yeah, I think one just other point I wanted to make that I don't think we've made yet is how differently we should think about the differential in patients who come into our healthcare systems with diarrhea present on admission versus those who develop diarrhea in the hospital, where the differential from an infectious standpoint becomes much narrower. And we really only worry about things like C. diff or norovirus if we're in an outbreak setting, but foodborne transmission becomes much, much rarer. And so our threshold for using some of the multiplex testing that Dr. Armias described should be much, much higher in a patient who develops diarrhea after being in the hospital for a while than somebody who's had community exposures.
Yeah, those are some great points. The setting truly matters, whether someone has been in the hospital for long periods of time or not. Absolutely. Dr. Tobin DeAngelo, a couple questions I think for you. One that I just noticed in the chat as well. Where does hepatitis A fit into the enteric pathogens that you monitor?
Yeah, so hepatitis A organizationally sits with our hepatitis team. We collaborate really closely if there ever are foodborne exposures. We work really closely with our environmental health teams on ensuring food worker exclusion, things like that. We have had several foodborne outbreaks of hepatitis A through the years. So we collaborate really closely when those do occur. They've not been extremely frequent, fortunately.
Right, great points. Another question, excuse me, for you, and this might be something that I'll expand to some of the other panelists as well. Some of the data that you presented to, it appeared that some pathogens are increasing in incidence and potentially even prevalence as well. And so one of the concerns from some audience members is that, is this true? Is this a reflection of our increased ability to detect some of these pathogens? What are your thoughts on that?
Yeah, one of the emphasis in recent years in that FoodNet MMWR that I alluded to is the characterization of culture-independent diagnostic testing. And I think that's one of the big advantages of our FoodNet surveillance is I think we delve a lot more clearer into the test types that are coming in within our enteric disease surveillance system. And that Yersinia line in particular, I mean, I'm not going to say that's all PCR positives, but it's we have definitely seen for Yersinia in Vibrio in particular, I would say increases since some more frequent use of the multiplex panels. The time frame that I included in some of those site-specific, state-specific figures, did include the, the COVID era too. So I think for some of them, there was a bit of a decrease and then an increase. So it'll be important to characterize these things moving forward and assess which cases were culture confirmed versus not culture confirmed. Thank you.
Great points. Dr. Gottlieb, from a healthcare system perspective, going off of what Dr. Tobin Angelo just mentioned, with these multiplex systems, is this something that you foresee being rolled out more and more potentially to improve the quality and the early detection of care for these patients? Is this something that, healthcare systems, especially in our region, should be looking to more?
Absolutely. And I really look at these panels as both a blessing and a curse. I think they're hugely advantageous in just the rapidity with which we can get results back and also the sensitivity compared to stool culture. But with that, we often lose the specificity. And so diagnostic stewardship, thinking about how you're going to utilize these panels, thinking about how we might limit them for testing of hospital onset infection, for instance, or potentially developing clinical decision support tools to understand which test might be appropriate for which patient. Like Dr. Ermias mentioned, her patient had testing for parasites, but had only been symptomatic for a few days. How can we really guide people to use these tests appropriately? But I do think we're going to see them more and more.
Yeah, so Dr. Ermias, thank you, Dr. Gottlieb. Dr. Ermias, last question to you along with that. Talk to us more a bit about that parasitic diagnosis that you mentioned that Dr. Gottlieb just referred to, because I think this is often a point of contention and misunderstanding when we think about what tests to actually look at ordering.
Yeah, so I think this goes back to taking a detailed history and making sure that you know what's going on with the patient before ordering the tests. And so really being careful and cautious about thinking about how long symptoms are going on for in general and the type of diarrhea the patient might be having. These can give you clues, like Dr. Gottlieb mentioned in her talk, about the etiology of the different types of diarrhea that a patient could have. And so for parasitic infections in general, I try to avoid sending any of that testing in patients, one, who either have not had a significant travel history, or two, are not having diarrhea that is ongoing for less than 2 weeks.
Excellent points. All right, I think we'll close with that. And I just want to remind the audience that in 6 months, the World Cup is coming to the United States, North America in general, too. And so be on the lookout for foodborne illnesses. And I think a lot of the points that were raised here will serve quite useful. So with that, we are going to close, but before we do officially, I just wanted to put some poll questions up on the screen. One poll question that is, for our audience now, having gone through the session, how knowledgeable do you feel now about current risks from foodborne illnesses? And while the audience is voting, I do want to say once again, a heartfelt thank you to our panelists for their wonderful presentations today and to our audience for their participation. And as we end the poll right now, as you can see on our screen, we have made significant inroads, our panelists have, and a lot of the knowledge has shifted to the upper portion of the curve. So thank you so very much to, again, everyone for participating today. Thank you to our ECHO team. We will see you again soon, and resources and post-session follow-ups will be posted on our website next week. Thank you all, everyone.